Good morning, everyone. Welcome to the webinar series 2020 Talk 5. Apologies for the delay. There was a little connection issues, but we sorted it out and we are ready to start. Today, we are joined by Dr. Partha Sarathi Das. He's a reproductive endocrinologist and infertility specialist. He works in Dubai. He's from Orchid Fertility Center. Today, he'll be talking to us about infertility. Welcome, Dr. Partha.
Good morning, everybody. Thank you, Biswajit, for the kind introduction. It's really nice to connect back after so long years. Yeah.
Yes,
it's
yes.
really nice. And
Certainly, after a long time, yes. So, Dr. Partha, before we get started on the talk, can you tell us a little bit about yourself, background, where you work, what kind of work you do, and then we get started on the talk, okay?
Absolutely. First and foremost, I would like to tell our all friends out there online, very good morning, and I hope all of you are healthy and stay put at home and safe, right? So, I'm Dr. Parth, and I hail from the northeast part of India, which is Assam. And then, yes, after my post-graduation, I did my super specialization in assisted reproduction technology genetics at Jaslok Hospital and Research Center in Bombay, India, followed by fellowship trainings abroad and masters in Spain and all. And then in 2006, relocated back to Dubai. And since then, just doing IVF treatments and fertility treatments and increasing the population of the world. Yeah. So, so this is what it is. And today, the topic which I've selected is unexplained infertility. The name itself is so unexplained that it starts where everything ends. So it's a very diffuse topic. It's a little elaborate topic. I'll try my best to squeeze in time. Just bear with me in case if there is any doubt or confusions about not understanding any particular point. Would love to address those issues at the end of the talk. Yeah.
Okay, I am running the presentation and Dr. Partha will be speaking, so there may be a little mismatch. Apologies for that. So Partha, if you're ready, then we can get started. Just make sure. I think some people are saying there is an issue with the audio. Everybody can hear and hear Dr. Partha and see the presentation? Just making sure, Dr. Partha.
Yeah, sure. I'm sorry about these glitches. I don't know why it's happening. It never happened before, but I don't know.
People are saying they can hear. Some people are, I think, maybe sometimes this internet, this is always a problem with webinars, but yes,
I know. And now everybody is at home doing online schooling and all.
Yeah.
So.
Yeah, I think bandwidth problems, I think everybody's doing webinars and online. My child started online classes now. They're having karate classes online, yoga classes online. So everything's online.
All right. So
anyway, I think most people are able to see you. So I think you can go ahead. Just indicate when you want the slides to be changed. Okay, Partha?
All right. So
all right. You're good to go.
You can change the slide. I'll start from the first slide.
Yeah.
So the first slide, which is unexplained infertility, as I told before, you can change the slide. Yeah.
Yes.
So now herein I'm talking about not infertility. I'm talking about those couples who already had been diagnosed as not able to produce a child or a pregnancy, and then they have come to us. So it starts from there. So these are the couples where everything has been evaluated. Everything has been evaluated in the sense that the woman's hormonal profile is matched. It's good. The scans looks good. The tubal test looks good. And there is no problem in the men in terms of the count, motility of the sperms, and the morphology. And still these couples are not able to achieve a conception. So as per the Royal College definition, it says that anybody who has been trying since 12 months, and for those ladies who are more than 35 years of age, it's reduced to 6 months duration. And a lot of institutions in the world have the same understanding and the meaning of the concept, where the uterus is normal, the cervix is normal, the fallopian tubes, ovaries, the functionaries of the whole pelvis is good, the coital functions are good, the man is absolutely brilliant, there is no problem, and still we cannot achieve a conception. That's what is unexplained infertility. Can we go to the next slide, please? Now, prevalence. 6 to 30%. It's a huge variance. Why? Because of the testing abilities, because of the resources available, which is the technicalities available for the to test. Countries, highly developed countries where we have good expertise and technologies, the prevalence is as low as 5 to 6%. But in countries where we don't have much resources and technicalities and expertise are not available, then it is as high as 30 to 40%. Right? So we go to the next slide, please. Yes, the potential contributing factors for subfertility. Now we have to understand a simple basic mechanism. Pregnancy can be compared to the simple theory of the seed and the soil theory. A very healthy seed implants or gets fertilized in a fertile soil. Likewise, the gametes, which is the sperms, when it fertilizes the egg, the resulting seed is the embryo, and when it gets implanted in the uterus, it can result in a pregnancy. I'm sorry, I'm not able to show you the cursors and all, but the pictures are there to self-explanatory. Now, if anything goes wrong with the seed or the soil, then the problem starts. All right. Now, here in unexplained infertility, we are not talking about the macro defects. We are not talking about the macro pathologies. We are talking about the microscopic, the unseen variety, the things which we don't easily get to see with our eyes. Now, worldwide, the reproductive medicine endocrinology school says that 35 years in a woman's life is the cutoff mark. Any lady who is more than 35 years of age, it is supposedly understood that the quality and the quantity, the reserve of the ovary gets compromised, and that becomes a little challenge for that lady to achieve a conception. And it could be in the form of low site quality or a low ovarian reserve. Lifestyle factors do play a very important role. Tubal functions. Now, herein we are not talking about a blocked tubes. No, they are open. The tube test has been done, and it has been told that the tubes are open, right? And still we say it is unexplained. We are talking here about the microscopic, the ciliary movement defects of the tubes. We really don't know what's happening inside the tubes. Embryological defects, like is the sperm able to fertilize an egg? We really don't know. Semen defect. Now, these sperms are absolutely brilliant. The count is good. The morphology is good. The motility is good, but still they are not able to get pregnant. Is the DNA of the sperms fragmented? We really don't know. Probably could be a reason. Endometriosis, adenomyosis. Now, we are not talking about the chocolate cyst. We are talking about those microscopic chocolate burns deposits and all around the pelvis, which can cause subtle adhesions and inflammatory conditions. Immunological, the unseen variety. I'll talk about it later. And the big one, the psychological issues. I kept it as a last point, but it is a very, very important point where people are not able to discuss and these issues openly in the community with the doctors, and they suffer silently, and that could be a reason for unexplained infertility. Next slide, please. Now, incomplete assessment. Now, where do we lag behind when it comes in the form of assessment for the males? Do we really know that? Now, this male, the sperms are normal. They are supposed to be a good count in a motility, and the tubes are normal. But are they able to travel to the tubes at all? We really fertilize it. We really know. Is there any check for fertilization profile of the sperms? We really don't know. And even if a sperm DNA fragmentation has been tested, still we don't achieve a pregnancy. Probably something more than that. When it comes to female factors, quality, quality, and quality. Egg quality plays a very important role. Do we have a marker or a test for the same? We really don't have it as of today. And a patent tube always does not guarantee a bidirectional ciliary movement. And not every endometrium implants an embryo. Why? We don't know. And that is what we call implantation failure after IVF. And that's quite challenging for us. Now, I will just go in brief about all those factors that I had mentioned right now, and lifestyle factors being the top of it. Now, smoking, alcohol, obesity, stress, pollutants, chemicals, everything plays a very, very important role, not only in fertility but overall in our general health. And when it comes to fertility, bang on, it goes and damages the DNA, and DNA damages means abnormal embryo development and infertility. So it causes a lot of hostile environment in our body, which does not makes the body conducive for a pregnancy and a successful outcome. Now, coming to the ovarian reserve. Now, what is ovarian reserve? Ovarian reserve is the number and the quality of the remaining oocytes. So what happens is a woman is born with a finite number of eggs at birth, unlike men. as of today, if a lady who is 35 years of age, she is going to ovulate a 35-year-old egg versus a man who is going to ejaculate a sperm, his sperms are made around 65 to 75 or 90 days back. That is why the fertility potential of a man is much better than a woman, because everything happens inside a woman's body, starting from the egg. So these eggs are supposedly or genetically supposed to be normal. And as we understand a classroom, the first benchers are the brilliant students and the back benchers are not the best students. So in a woman's life, the early age 20, 25, 30, they are the ones who releases the best eggs, and that is why the fertility potential of these women who are young in age are the best, as compared to ladies who are 35 and more than 35. They probably don't have that good quality of eggs to ovulate, and that is why the difficulty in achieving a conception after 34, 35 years of age. So the pictures which you get to see on the screen right now, on the top hand right hand corner, you can see a ovary which has got around 5-6 follicles, which is a normal ovarian reserve. Every cycle, there is a recruitment of 4 or 5 follicles and one undergoes dominance. If you see the bottom slide, there is an ovary which has got around 10-12 follicles, and this is what we say is the PCOD. This is a state of excess, hormonal disbalance. And the other slide shows diminished ovarian reserve, where hardly 1 or 2 follicles are there. So we get which one can give us a pregnancy. Sometimes, it's very, very difficult for us. Sometimes we get pregnancies from the diminished ovarian reserve. When there is no eggs, we end up getting pregnancies, versus the other side, which has got too much, and still we don't achieve a conception. So it's very enigmatic. Now, continuing with the diminished ovarian reserve, if we understand the physiology of what the ovarian compartment and the follicular genesis is, like at birth, the woman is born with that finite number of eggs of 7 million, and it keeps on depleting. It keeps on undergoing a physiological atresia. So by the time of puberty, it's around 300,000 left. And throughout the whole reproductive span, this woman will ovulate around 400 to 500 cycles. And by the end of menopause, there is nothing left, right? So why do we then have at 29 or 30 years of age something called diminished ovarian reserve? Means the reserve, the egg capacity is so not good that there is no egg left for fertilization. Probably there is no scientific study per se, but scientific the concepts which have come forth is probably these are the group of women who were born with a reduced number of eggs at birth. Probably they were not born with 7 million. They were born with 4 or 5, and by the time they reach puberty and reproductive age group, it's all gone. Or probably there is a rapid atresia of the normal pool of the oocytes, right? So this is how the diminished ovarian reserves happens. And now it has been also seen that fertility issues are directly, next slide, please. Yes. Now, fertility issues are directly or indirectly related to early menopause, and both these events are expressions of accelerated ovarian aging. Now, 13 years. 13 years is a magic number. Now, this was a very important study which was presented in published in Human Reproduction, and they said that from the onset of rapid fertility decline to the menopause, it is 13 years. As for example, if somebody attains menopause by 45 years, then your rapid decline in fertility or the ovarian aging has started as early as 32 years. Now, in our practice, we get to see ladies of 30, 32, 33, 34 years. Now, if this concept has to be taken forth, then we are actually in a hot seat. We have to finish this thing as soon as possible. Otherwise, this lady will have no eggs left in her ovary to achieve a conception. And that is when we have to say that, okay, now listen, if you want to get a pregnancy, then probably we are done with this ovary. Now we have to go in for third-party reproduction, and that becomes another Pandora's box to accept the things of achieving a conception. Can we go to the next slide, please? Now, shifting from the ovaries, we go to the tubes. Now, as I have told before, these are the tubes which are patent, right? These are the tubes which the hysterosalpingogram has shown that it is open and it is good. But is the microciliary, if it is open and if the sperms are normal, why then it is not happening? Is it that the microciliary functions are not happening and that it is not migrating the sperm from one side to the other side? We really don't know. Now, if you see the first slide, now normal mucosal rugose fold and all, it's a normal tubal mucosa, as compared to the second picture, which is absolutely bald. It is absolutely nothing is there. There is no ciliary, there is no mucosa, and this probably could be a sequelae of any kind of pelvic infection. The third slide shows dilated, engorged vessels, probably a kind of an inflammatory or self-ingitis. The additions on the fourth slide shows additions, again, a sequelae of infection. rounded edge of mucosal folds, again, probably could be some kind of an infection or an inflammatory procedure. And the last one shows a small mucosal debris, and that is where the prophylactic and the therapeutic effect of HSG plays an important role. So yes, in our kind of population where we see the Asian population, the pelvic infection, notably tuberculosis, plays a very, very notorious role in terms of tubal microscopic ciliary defect. And this is where we have to understand and rule out infection, and you have to have a strong suspicion of TB, because TB, unlike the lung tuberculosis, which manifests with a lot of hemoptysis and chest infections and all, endometrial or latent tuberculosis is very dormant. It is very silent. The only symptoms which presents with is infertility, bad obstetric history in the form of repeated ectopic pregnancies, and when you do a scan, you get to see a very thin endometrial lining. So when you do a biopsy, endometrial biopsy in this group of people, most of the times the TB test comes positive. Can we go to the next slide, please? Yes, endometriosis. Now, this is the endometriosis which is invisible, unexplained. These are not those chocolate cysts which we have, the big ones. These are the small microscopic defects that neither the patient knows, neither the physician sees it. But if there is a history of dyspareunia, dysmenorrhea, or when you do a scan, there is a slight probe tenderness, then probably you might have to suspect that there could be an underlying rectovaginal endometriosis or pelvic endometriosis or microscopic deposits, which we don't know. And what does this endometriosis do? It causes an inflammatory condition which are toxic to the eggs and sperms. And if these deposits are all around the pelvis and the ovaries and the tubes, it does cause scarring of the tubes. If it causes scarring of the tubes, it causes an anatomical distortion. So the migration of the sperms and the embryos doesn't happen. And if it's on the ovarian surface, then it can cause scarring of the ovarian surface and it does not lead to ovulation. So again, we are back to square one, which is infertility. Can we go to the next slide, please? Coming to adenomyosis. Now, this is the endometriosis of the uterine musculature in the myometrium wall, and it makes the uterus big, bulky. And progressive dysmenorrhea is one of the findings which the patient usually presents with. Now, when we see this kind of a picture, it really annoys us, because this endomyometrial cyst, which you see in the picture, it is enough to release that gooey chocolatey fluid into the endometrial lining. Always making a layer of fluid in that endometrial lining does not let the embryo implant and grow. And also, again, it is toxic. And because of this bulky uterus and distorted uterine size, it distorts the anatomy, pulling the ovaries quite high up, making the ovulation quite defective. Can we go to the next slide, please? Now, shifting from the endometriosis, we go directly into the bed of the baby, which is the endometrium. Now, this picture, what you see, you can see it's just measuring 1 millimeter, I guess. It is so it is a nightmare for all of us to see such a lining, and it basically a very bad endometrial lining, probably a sequelae of Asherman syndrome or endometritis. We really don't know. And if it is endometritis, mostly because of pelvic infections like tuberculosis or chlamydial infections, we really don't know. And as mentioned before, if somebody comes and presents to you saying that I have difficulty in taking a pregnancy forward, I had got 2 ectopic pregnancies, and my tubes were cut off, and then on scan, when you see an endometrium of 1 millimeter, 2 millimeters, go ahead and do an endometrial biopsy. Maybe you can be test positive for the tuberculosis, and then maybe you might have to give treatment for the tubercular therapy for 9 months. Yeah. Can we go to the next slide, please? Next slide. Yeah. Now, out of the pelvis, we go to the psychological issues. Now, this is so big. It looks very simple, but it is very significant. These are the couples who doesn't talk much. They silently suffer. And when on poking and on repeated questioning, they come up and say that they have a problem in penetrative intercourse. They're not able to have intercourse, or somebody has not even consummated the marriage. And there are people who say that, doc, we really don't want to get into all these things. Just get us a baby by doing the artificial reproductive technology procedures. Trust me, I have done a lot of IUS and IVF for these kind of couples who are very clear about their life, what they want out of it. And many of the ladies have this vaginismus, or the penetration is difficult, so on and so forth. Or some people have no basic understanding of what is the physiology of reproduction. They are so stressed up when it comes to the mid-cycle that there is no sperms left on ejaculation, and they are back to zero. So making them understand step by step what is the safe period and unsafe period of the whole cycle, and educating them about this whole process really helps. And of course, talking with a couple or escalating them with a psychologist really helps them. Now, male factor. Now, these are the group of men whose sperm count are normal and they have a good count of motility, but they come and say that they are not able to have a conception, or probably there are a group of people who have been having repeated miscarriages. Now, these are the group of people we need to talk to them and say that probably there's something called DNA fragmentation and of the sperms, where the DNAs are clipped and chopped such that when it comes to making, we all know that the DNA exchange happens between the gametes. So when there is a break in the DNA from the men's sperms, that break can lead to abnormal genetics. And if the part of the chromosome which has led to implantation and an embryo formation and a pregnancy, by the time they reach to 6 weeks and 7 weeks and the proteins are released to make life, and if that part of the DNA is fragmented, that information is not real to the embryo, and that is why we end up having miscarriages. So DNA fragmentation is a very important cause of infertility or repeated miscarriages. All right, now shifting, next slide, please. Now, immunological, this is the immune dysfunction. Now, we all know pregnancy is so unique and it's a nature's miracle because a living being of a completely different genetic makeup is accepted and tolerated and nurtured by the maternal immune system. And it is unique because it goes against the laws of the classical transplantation immunology, right? And what happens during this pregnancy is that maternal immune modulation happens. There is an acceptance in the maternal immune system. There are some modulation of those immune cells in the mothers, which skews the whole physiology of pregnancy towards tolerance. Now, the root cause of any problem, including infertility, is inflammation of the body. All right. Now, the cytotoxic T cells are the ones which are the destroyers, right? And in most of these ladies who are having infertility problems or immune dysfunction, the cytotoxic T lymphocytes are quite elevated. But in pregnancy, there is a dominance of a specific group of cells called the T regulator cells, what is called the TREG cells. And they are the ones which modulate the pregnancy, and they are the ones which decreases the TH1 dominance and elevates the TH2 functions of the body. Next slide, please. Now, as I mentioned before, the TREG cells, 2 days after post-fertilization, these TREG cells populate the systemic and the decidual environment, which favors implantation and morphogenesis of the placenta. It suppresses the TH1 activity and inhibits the T cell proliferation, and also inhibits the T cell cytotoxicity. Next slide, please. This picture also shows the same thing. The TREG cells has got a positive influence on the TH2 as well as the inhibition effect of TH1 and TH17. Next slide, please. Now, this was one of the tests or probably a study which was done in my parent unit in Jaslok Hospital and Research Center in Bombay, and where we had evaluated this group of people who were having repeated miscarriages or unexplained infertility or long-standing infertility or implantation failure, where we were doing multiple number of IVF cycles and implanting the embryo, and they were not getting tested. And we tested the blood for the anti-ovarian antibodies, and most of these ladies ended up being positive for these anti-ovarian antibodies, which is an autoimmune dysfunction. And when we did the immune modulation treatment in the form of steroids and trilipids and IVIG, most of them they ended up getting pregnant, and not only pregnant, taking the baby to term. And then that's what the postulated theory which we put forth was that anti-ovarian antibody testing could be included in the battery of infertility investigation and treatment. Next slide, please. Next slide, yeah. Now, this is a case scenario which I have put across, probably quite interesting for gynecologists, but here we have a mixed group, so I will come back to these questions later on. Next slide, please. Now, we all understood what can happen in the microscopic level of unexplained infertility. Now, straight away delving into diagnosis. Now, baseline hormonal test, which is a part of the evaluation process. Anti-Mullerian hormone, what is it? It marks the ovarian reserve. Less than 2, suboptimal. More than 2 is a good ovarian reserve. Means your ovaries and have got good number of eggs left. Thyroids and prolactin tests to be done, scans to be done. Already this lady has been subjected to multiple scans, but these scans to note those microscopic endometriotic deposits, to note for any pelvic discomfort, or a probe tenderness to elicit in case if there is an endometriosis. The men are subjected for a DNA fragmentation test, and if there is any NK cell activity, we do those tests either from the blood or the immune from the endometrial sample. And of course, laparoscopy and hysteroscopy forms an important part of evaluation. Next slide, please. Now, what are the prognostic markers? If a couple comes to say that we have been trying for the past 2 years, yes, you have a good prognosis. We can do something very simplistic, minimalistic, and the chances of attaining conception is good. If a lady is less than 35 years of age, yes, the prognosis seems to be good. Why? Again, it comes back to the same concept: good ovarian reserve, probably good quality eggs. Can we have the next slide, please? Now, treatment is a detailed consultation. We spend a lot of time talking to our couples, discussing the pros and cons of every treatment, and the consideration to be taken are the age, duration of infertility, and availability of the resources and the technology that we can use. At the very sitting, with this couple, we need to talk. See, fertility treatment is not like a branch of medical or surgical specialty. In a surgical branch where you chop off the appendix, and there is no problem with appendix later in life, or a medical guy gives an antibiotic and you're good for life. Infertility, we are always talking about negatives more than positives, ifs and buts, may not, might not, chances of success, chances of failure. And this is what happens when we make a life. So a fertility roadmap needs to be discussed with these couples, outlining the success rate and the cost factor too. Now, here in most of the centers in the world, the IVF centers, these are all private institutes. Very few centers are research or university-based centers where it's government funded. And the approach should be starting from a very low cost, low tech treatment, and gradually going to the high tech treatment. Next slide, please. Now, of course, the basic counseling and education is the basic ones. Change starts from home. Exercise, good food habits, good sleep, lots of fluids, and maintaining mindfulness. These are the things which I think we all know, but we all need to talk again and again and again. And this is where things has to be stressed upon. The next slide would be the evidence-based recommendations for unexplained infertility management. Expectant management is like wait and watch policy. If not, we can always do a laparoscopy, hysteroscopy. If not, we can give some medications in the form of tablets and injections, and then we can do IVF ICSI. And of course, throughout this process of treatment, psychological counseling is of paramount importance. Next slide, please. Now, expected management is wait and watch policy. Now, we have to understand one thing. These are the couples who have waited 2 years, 4 years, 5 years, 6 years, and then come to you, and then you say, okay, see, as per the books, they say expected management. So again, go back home and try naturally and see if it happens. No, they will never come back to you. So we have to be very, very individualized and case-to-case basis. We have to tailor make their whole plan. Somebody who's 35, 36, who waited for 4 to 5 years, I don't think so doing an expected management would be feasible in her case, So we have to individualize the whole thing. And what is individualizing? Means you come back for a regular monitoring. If need be, you take some medicines, and then we will see your ovulation, and then we can advise you either time sexual intercourse or IUI if need be. Next slide, please. Now, what is the role of laparoscopy or hysteroscopy or any kind of endoscopic surgeries? And is it mandatory that anybody who has come to us at 2, 3, 4 years of infertility with no problems, no pelvic anatomical pathologies, okay, now that you're unexplained, do a laparoscopy? Absolutely not. If everything is fine and there is no suspicion of any pelvic disease, she doesn't warrant a laparoscopy or a hysteroscopy. Yes, sometimes we do multiple implantation failures just to see with our own eyes what is happening inside, because sometimes doing a laparoscopy and seeing with own eyes is much better than a scan picture, right? And sometimes doing a diagnostic laparoscopy reveals a lot of endometriotic deposits and adhesions which we can take care at that time. Now, indications of laparoscopy, hysteroscopy are many. It's like young age, less duration of infertility, resources available, no financial constraints. There is a presentation factor of dyspareunia, dyspareunia. Yes, we can go ahead and peep inside the pelvis to see if there is any problem. We can also do a chromoperturbation to check the tubes again, and then we need to do the needful. But also, what happens in many places, what happens, okay, you are a PCOD, let's do the ovarian drilling and see how it goes, and it'll make you pregnant. And many a time the ovarian surface has been cauterized to control the PCOD, and you will get pregnant, and the lady never gets pregnant. And when she comes back after 1-2 years, we see that PCOD has converted to a diminished ovarian reserve. Why? Because it has burned all those follicular things and made the ovary so fibrous that there is no eggs left. So we have seen so many cases where a PCOD has converted to a state of diminished ovarian reserve, and they have a tough time getting pregnant. So yes, PCOD does play an important role, but you have to tell that if nothing happens within 2 to 3 months, don't waste your time anymore, right? But again, laparoscopic ovarian drilling has taken a backseat and nobody does it anymore. Next slide, please. Yes, these are those laparoscopic pictures and hysteroscopic pictures, which shows endometriotic powder-borne spots all around the pelvis. And the hysteroscopic picture shows fibrosis in the ostial region and small white spots, which are the telltale signs of tuberculosis. Can we go to the next slide, please? All right, so now we have done laparoscopy or hysto, and we have done expected management. Now let's a time to give you some push to the ovaries to make some follicles and get some eggs ready. Either you can use some tablet protocols like clomiphene citrate or letrozole, or you can add some gonadotrophin injections, do a regular scan, do a follicular tracking. If there is an ovulation, advise them IUI or probably time sexual intercourse. Next slide, please. Now, this is the recommendations from the Canadian Fertility and Neurology Society released in 2019, and they're very crisp about it. They say that laparoscopy is absolutely not warranted in unexplained infertility until and unless there is evidence for tubal or pelvic pathology. Natural cycle and IUI means just scan in the natural cycle and do an IUI? Absolutely not. You do a clomiphene citrate and tell, go back home and try? No, you don't do that. You give a letrozole and say, go back home and try? No, it doesn't happen like that. You give injections and say go back home, doesn't happen like that, because you need to see the eggs forming. You cannot just leave anybody alone home like that. IUI and then you give clomiphene citrate or letrozole and then do an IUI. Yes, it is indicated. What to give, whether you need to give the aromatase inhibitors like letrozole or you need to give the clomiphene citrate, that depends upon the discretion of the physicians, which works good for which patients. Whether you want to give injections and do an IUI, brilliant idea, you can do that. But you have to understand that injections with and then do an IUI, the chances of having multiple follicles are more. As a result, the higher pregnancy chances are more, multiple pregnancies and the obstetric complications and cycle cancellation rates are more. So we don't want to increase the risk of multiple pregnancy by giving injections and all. And the last 10 would be IVF if all the cycles have failed. And if somebody has done 2 to 3 cycles of IUI, the next bet would be to escalate to an IVF ICSI cycle. And the last point which they say is do IVF then ICSI. I think it is reserved for the tertiary care centers in research-based institute where it's government funded, where they don't want to do too much of ICSI because of the cost of things, where IVF is more simplistic than ICSI. But nowadays in most of the IVF centers, it is ICSI the way forward. This was a study published in Fertile Sterile, and which says that which is better, letrozole and clomiphene. It all depends on the description of the physician. Which works good for one might not work good for the other. So you have to decide as and when, as and how it goes, and what suits the patient best. Again, the same thing, evidence-based approach in unexplained infertility. The only thing they say is individualizing the management of the patients. You have to take it as a case-to-case basis. So coming back to the same teaser question which I had put before, this was a lady who had seen me at 30 years of age, married since 5 years, and first pregnancy she had a MTP because of an unplanned pregnancy, and then she got pregnant after a year, and it was a chemical pregnancy. And now she came to us saying that 2.5 years we have been trying. Her anti-mullerian was 4.7 AFC. She had a mild PCO. Semen test was normal. Tube not done because she got pregnant. So what is the way forward for her? So in this case, we planned that we will do few cycles of IUI. If not, then we will resort to IVF. We started off with clomiphene citrate and gave some menopause injections and scanned her on day 12. There were 3 follicles. She did not get pregnant with IUI. Second cycle we did, again, the same thing. We gave clomiphene citrate and gave injections menopure, and again, 3 follicles, but absolutely no pregnancy. Then we resorted to another cycle of IUI, but this time there was a change of plan. It was a kind of a little bit of a mini IVF stimulation in the form of aromatase inhibitors and Latara with a gonal-F, recombinant FSH, and HMG. And she again had 3 follicles, but this time she got pregnant, and right now she's in her 8th month of her pregnancy. Now see the pattern of this woman. She, every time, whether she takes injections or tablets, she has been making only 3 follicles. She, on her evaluation, she was a baseline or a moderate variety of polycystic ovarian pattern. But on high dose of tablets or high dose of injection, she is continuously making only 3 follicles. Probably what was the difference in the last cycle was that she needed that extra boost from the gonadotrophin injection. Probably it is that gonadotrophin which changes the genetics and the oogenesis and the embryo quality, which has probably given the successful result. All right, so we have done 2 to 3 cycles of IUI, nothing happens. As per the American Society, they say go ahead and do a good cycle of in vitro fertilization procedure. Right, now we embark into an IVF ICSI program. Now, when we start with an IVF ICSI program, we have to continuously talk and counsel our patients, because it's a lot of things. It's a lot of time, the money, the logistic, the professional career, so many things, family involved, a lot of things happening, a lot of stress factor, a lot of sadness that nothing has happened, and now they have to do IVF, and they feel that IVF is such a bad thing in the world, which is absolutely not. We have to talk of that, okay, with this years of infertility and age and the ovarian reserve, the sperm test, egg fragmentation, or we can do a hysteroscopy. We can offer them genetic screening to know whether the embryos are indeed genetically 24 chromosomes normal, and of course, immune modulation. All right. So next slide, please. Yes. Now, IVF education starts with a very good counseling, and we have to make our couple understand that just because you have a good ovary and we see follicles does not mean that it will result in the maturation of an egg. Or if there is a sluggish folliculogenesis, means the egg is really not growing, suspect quality issues of the egg. That could be a hindrance. That could be the answer to your unexplained infertility. If you need a lot of injections to make an egg, suspect quality issues. And also we have to understand that not every egg that fertilizes will result in a good quality blastocyst for implantation. And if you had a very difficult IVF stimulation, usually it results in a suboptimal embryo quality. Again, quality issues. So you see, everything is resulting in at the level of the DNA. It's a level of the quality issues that we have to talk. And then if we have got enough eggs and embryos, then whether do a fresh embryo transfer or we do a frozen embryo transfer. Because when we do a stimulation, the estradiol levels can go so high that we can end up getting ovarian hyperstimulation syndrome, which is again a huge, very risky complication of any in vitro fertilization procedure techniques. But nowadays, we are having almost OHSS, ovarian hyperstimulation syndrome, zero clinic or OHS free clinic because of remarkable use of agonist triggers, right? So we go to the next slide, please. Now, this is the picture of an egg after egg harvesting of IVF, and see the poor quality. This is what we see, a very poor quality egg where we have a large perivital in space with granulation, duplication of the zona pellucida, and a granular cytoplasm with cytoplasmic inclusion. Now, if a sperm is injected inside this egg, probably, and chances are very high that it will not fertilize, or even if it so fertilizes, it might not propagate into a embryo, or it might get arrested. Can we have the next slide, please? All right. So this is an embryo. If you, Biswajit, if you put the cursor there, and if you can probably run the video, I can show you how this embryo, you know, what the problem of this embryo is.
Partha, the video is not running. Maybe at the end of the session, we'll try.
Okay. No. Okay. Okay, no problem. So this was an embryo where we had to, where we probably one of those very rare embryos I've seen in my 16 years of my career, and huge vacuole which boom, it blasted off inside, and you know the whole embryo got degenerated. And because we have the time lapse embryo monitoring, we could record all these things. And this tells us about the embryo quality issues. And you know these are the ones which tells us that you know indeed the egg quality or the sperm quality or the embryo quality is not so good, which could be the result of unexplained infertility. Can we go to the next slide, please? Now, let it go. So it's fresh versus frozen embryo transfer. So all this while we were doing fresh transfers, but now with advancing technologies of frozen cycles, like where we freeze the embryos, and we have found amazing recovery rate of these embryos because of absolute brilliant technical skills of the lab. We have gone to the frozen cycles, means we do IVF in one month, and the next cycle we put the embryos back. We don't do it in the same cycle. So that has maximized and taken our success rate almost 60 to 70%. And but is it being done for all? Absolutely not. Can we have the next slide, please? Now, this is one of the studies which was shown that, does embryo cryopreservation stress the embryo? Does it make it bad? No. It has been shown that it also reduces levels of reactive oxygen species in the embryo and detoxifies the cells, and it really, really reduces the embryo stress. And this could be a repair mechanism inside the embryo, if at all it was there. And these are the embryos which do implant, and that is why we see a good success rate after frozen embryo cycles. Next slide, please. Now, what are the indications? Who are the patients who needs to go for deferred embryo transfer, or what we say is the sequential embryo transfer, or a frozen embryo transfer? Like somebody who is polycystic ovarian syndrome, who has got many eggs, who has got many embryos, and their estradiol levels are very high, and they are at high risk of ovarian hyperstimulation. We cannot put the embryo, because putting an embryo will ignite that whole process of HCG, and it's going to make the condition worsen and up to the level of ICU, and probably many lives have been lost because of this. So yes, if nowadays when we see ladies of PCOD, they are actually the ideal candidates to go for frozen embryo cycle or deferred embryo cycles. And if while doing the IVF stimulation, if the progesterone levels are very high, that is actually detrimental to the endometrial lining. These are the ladies who need to go for deferred embryo cycles. Couple who desires to do a genetic screening or a family balancing, like they have two boys and they want a girl, or vice versa, they are the ones who needs to go in for deferred embryo transfer, because we do the 24 chromosome study and the report takes a little time. Or somebody wants to do they want to do the IVF and they don't want to get pregnant right now. They are focused on the carrier. So they come, they do the IVF, they freeze their embryos, and they go back to the carrier life. And then when they are free, they come back and then they replace the embryos. So what happens if this lady does at 30 years of age and then she comes at 34 years of age? So actually at 34 years of age, we are implanting a 30-year-old egg. So she gets pregnant very beautifully because the egg was of 30-year-old, and the chances for her to get pregnant is much better. Well, versus if she would have done the same cycle at 34, then there would have been a substandard egg quality. This was a second teaser question. 29-year-old lady who was married since 3 years, first pregnancy, natural conception immediately after marriage, but it resulted in blighted ovum. But her AMH was 0.4, which is absolutely abysmal. It was very low, hardly 1 or 2 follicles were there. FSH is 2.5, LH 2.7, AFC of 304, semen test normal. What is the way forward? So in her case, we did one cycle of IUI, which did not work up. Second cycle, we resorted to IVF because of diminished ovarian reserve, and it was the ideal way forward. So we did a good cycle of IVF. We got good eggs. 3 matured, but the embryo did not survive after day 3, and we had nothing to transfer. Then we had to resort to the third cycle. We started off with an IVF stimulation, but things changed after 10 days of injection. They wanted to do a little conservative. So what I did was do a IVF stimulation and resorted to and got her ovulated and asked her to do a planned intercourse. And lo and behold, she's pregnant, and currently she's 9 to 10 weeks pregnant. And this is what makes our day, So, and look at her age, 29 years, and she has nothing. This is a lady of diminished ovarian reserve, and very, very sad story. But at the end of the day, she's pregnant, but quite difficult. Now, there is something called endometrial receptive assay. Next slide, please. So endometrial receptive assay is something where we date the endometrium. This is a personalized embryo transfer, and this is specifically applicable when we want to put the embryos back in a subsequent cycle. And we have done it before. The patient did not get pregnant. So what we do this time is do it in a natural way or do it in a HRT cycle. We take a biopsy after 5 days of progesterone, and we see the endometrial progesterone receptor expressions. And the report says that, yes, it is pre-receptive, receptive, and this is the time we time and date it and put the embryo inside. And this has maximized our chances of implantation and pregnancy rate by 70% at least. We can do the next slide, please. Now, DNA fragmentation of the sperms we had already discussed. It is the chip, it is the clip of the DNA in the sperms, which can really result in infertility and miscarriage. Next slide, please. The next slide shows a lot of indications and causes of why DNA fragmentation happens. So many causes: stress, pollutants, environmental factors, and it causes a lot of not so good outcomes. Next slide, please. Yeah, so the treatment of the DNA fragmentation test is nothing but multivitamins and antioxidants. If there is a varicocele surgery, we need to get that varicocele out of the way, continue giving them the antioxidants for at least 3 to 4 months, and then subject them for a repeat test. And most of the times we do see the fragmentation indices has evolved. Now, why these 3 months is because the sperm generation is every 70 to 90 days, as I had told you before. So we are giving a chance for this DNA to get repaired itself and heal by itself. And many a time when we say that we do this treatment, many of the ladies, they do get pregnant automatically, and they don't need any further treatment. Next slide, please. Now coming to the unseen, the big one, the immune dysfunction, which is immune dysfunction, which can tick off the immune cytotoxic T cells in the mother's blood and can tick off the embryo, causing miscarriages or implantation failure. So how do we treat them? We can give them intralipid, steroids, IVIG, or low molecular weight heparin. Next slide, please. Now, intralipid is basically a milky white emulsion solution. It consists of egg yolks, phospholipids, glycerols. This was initially introduced in the premature units to give caloric supplementation to the newborns who were premature deliveries. And then science found its own use in reproductive medicine. And they found that it really, really boosts up the immunity also. And when this was offered to ladies who were having problems with infertility and miscarriages, a lot of these women did take the pregnancy to term. Now, many research centers in the world, they either believe in immune dysfunction in belief, and that's a personal call, and if they believe, then this is the treatment forward, which we also believe, and we are getting amazing results. And ours is a tertiary care center, and we are getting all these complicated cases, and when we do the treatment with this kind of modalities, it really, really helps. IVIG is the mother of all immune modulators. As we all know, it really, really suppresses the activated killer cells in the body and propagates a pregnancy forward. Next slide, please. But it is very costly, and it has got a little side effect, so it is on a case-to-case basis. This was one of the studies done which showed the beneficial effects of these immunomodulators like IVIG and intralipids on pregnancy outcome. Next slide, please. The same studies on a different this thing also shows the beneficial outcome by intralipid and how it modulates killer cell activity in a woman suffering from reproductive failure. And next slide, please. So these are the different studies which shows which are again biased, which are debatable in the community. The green ones are in support of the immune modulation treatment, whereas the red ones don't support the immune modulation during pregnancy treatment. So I think it's the whole world fertility. This thing they have taken as a personal call. Which one works best for which. They don't have much side effects and no harm. And so, it is on a case-to-case basis. Heparin, next slide, please. Heparin is, as we all know, the low molecular weight heparin. It does play a very, very important role in recurrent miscarriages, in antiphospholipid antibody syndrome, and also in our IVF program, we do give heparin because it does modulate the expression and secretion of TNF-alpha and induce decidual apoptosis. So it really, really maximizes the chances. Next slide, please. The steroids, yes, we have been routinely advocating steroids in our treatment after IVF. Not for everybody, of course, but for those group of ladies who are having immune dysfunction. TNF-alpha blockers, we really don't use it anymore now. Next slide, please. So again, another debatable thing, no concrete evidence exists that administration of immunomodulator enhances the outcomes. So it is still a debatable thing as published by Sankara in Human Reproduction. So next slide. Now, for me, unexplained infertility, more than that, it is the unexplained IVF failure, which really, really scares me because even after doing a lot of things like immune modulation, genetic screening, endometrial dating in the form of endometrial receptive assays, and then treating with hysteroscopy and laparoscopy, and then giving making the flora normal, giving them intralipid in spite of all these things, and also treating the normal DNA fragmented sperms. In spite of all these things, we still don't achieve pregnancy outcome. We have reached almost up to 60 to 70% pregnancy rates with an IVF, but still we have around 40 to 30 to 40%. We really don't know, and we are always in the process of finding out where exactly things go wrong, and still the study is ongoing. So next slide, please. To summarize, we have a stress and anxiety which can cause unexplained infertility, and the only thing which we have to understand that TTP, which is time to pregnancy, we need to reduce that. For somebody who has come with hope, we have to understand that from now until the next 3-4 months, we can achieve at least 40-50% chances of getting a take-home baby. And of course, lifestyle modification is important. Laparoscopy, hysteroscopy can be offered, but we have to analyze risk, benefit, risk should be weighed, and IVF has the highest chances of achieving a conception, but it has a cost factor involved in it. Individualizing the treatment is very, very important, and a fertility roadmap has to be clearly defined. Next slide, please. Psychological issues, of course, has to be discussed continuously with these people who are having a lot of stress and anxiety. Many times simple talking across the table also helps successful outcomes. And of course, reproductive planning in counseling is the need of the hour. We cannot just say a lady who's at 32, 33, go back home and try. No, we have to lay the importance. If it is needed for an IVF, we have to stress for IVF. And there is no shortcut to it, but to maximize the chances of take-home baby. So with that note, I finished my unexplained infertility, and just 4 or 5 slides right now in the era of coronavirus. What, as fertility doctors, we are encouraging our patients, and these are the guidelines from the American Society. Now, this was a very beautiful definition which I saw in the net by K. Elder, virologist, who says it's a fiendishly cunning, tiny disease-causing entity that mutates and evolves continuously, better termed as molecular pirates. And that is our great Mr. Corona, or Mrs. Corona, I have no idea. The symptoms and the things we all know. Now, what does the ASRM COVID-19 Task Force Guidelines tells us? Question 1, if I'm trying to get pregnant, should I stop trying to conceive due to coronavirus? Now, nobody says stop. If you want to continue, continue. But also understand one thing. If by getting pregnant, you end up miscarrying or having bleeding, you need to come to the center. When you come to the center, you're exposed to a lot of people, to the triad center, and a lot of patients getting treated. You might catch infection. So you need to understand all these situations. And the myth is we are free at home and let's finish all these things now and pregnancy treatment. No, it is absolutely unjustified at this point in time. We are next slide, please. We are ready to start fertility treatment. Is it okay to continue during the pandemic? As of now, as per the guidelines, we are not starting any new treatment, including IVF, IUI, or any ovulation induction. But whatever we had started, we are continuing it. We are usually freezing those embryos and not transferring those embryos. And any diagnostic procedures like tubal test or HSGs and all those things has to be deferred for the later things. IVF, IUI is not to be done. Any elective surgeries like hysterolaparoscopy, elective, should be deferred. Ectopic pregnancies, all those things has to be addressed. And we are making much use of tele-online consultations. We are talking a lot on phone and helping our people, with all those small queries they have. Can we have the next slide, please? Will contracting COVID-19 now impact fertility later? Now, it is still in the gray zone. Not only us, whole world is in a dilemma, what to do, what not to do, what is the best foot forward. We really don't know at this point in time. Is there any effect on the pregnancy? We really don't know. Is there any effect on the newborn baby? No, but a lot of babies have been delivered so far and they have been good. A lot of COVID pregnant women also delivered and the babies are still good. So as of now, nothing. So just the fear that, okay, I might get corona in the future, so it's better I go and freeze my eggs and make an embryo and keep it in use, and we will use it later once the pandemic is over. Absolutely, it's a myth. We should not do that, and there is no medical indication to go ahead and freeze your eggs and sperms or embryos for future use as a preventive measure. No. Can I have the next slide, please? What if I test positive for COVID-19? If you test positive for COVID-19, it is the same guidelines and the management as anybody else is getting positive. First, no fear. Please go and test yourself in the nearest center and take all the basic precautions that needs to be done. Isolate and wait until you're fully cured, until the pandemic is over, before you start your next reproductive technology treatment. Next slide, please. And what if I'm pregnant and I test positive? Again, the same things. If you test positive and if you're pregnant, you need to go and see your doctor immediately, because you're at high-risk population and you need to be managed by a multidisciplinary team. And again, the safe hygienic practices at home needs to be followed. Next slide, please. If I'm positive, can the virus be passed to my baby? As of now, in Wuhan, a lot of ladies has delivered. And next slide, please. Yeah, a lot of ladies have delivered without any detrimental outcome to the mother and baby. Vertical transmission is not yet established. Feeding the baby, they say, is absolutely possible. You can feed the baby. The only risk is when you hold the baby close to the mother's breast. There should not be any exchange of that, so you always have to wear a mask. So yes, there is no justification as of now, but studies are being still done. How do I take care of the stress and anxiety during the crisis? Next slide. Talking, counseling sessions really helps. Teleconsultations, we are available. If not, talk to your family members, whoever is close, kin or knit of a family, please talk to them. It is not only you, but everybody else, including us, who undergo depression, stress, anxiety at this point in time. It really helps talking it out. So yeah, I mean, this problem needs to be discussed. And of course, staying at home is the new normal. We need to get used to that. And yeah, good life, good things coming out of the way. So yeah, with that, I end my unexplained topic for today. And thank you so much for a patient hearing. Thank you so much. Thank you, Biswajit.
Thank you, Dr. Partha, for a very extensive talk on infertility. There are some questions coming in. Just to get it started, let me first maximize your screen so that everybody can see you. So you mentioned about tuberculosis as one of the causes. So normally, in India, it's very common. I know some people, some physicians, clinicians do anti-TB treatment straight away. Sorry, let's get your video back, I think. You can hear me, Partha?
Yes, I can hear you. Yes, I can.
Okay, so do in India, some clinicians start straight away anti-TB treatment if it is there any justification for that? I know TB is very common, but is there a diagnostic process, or is it a common thing to start off?
See, this is a kind of a problem which very rampant in our country, and also because the population is so diverse now. It's all over in the world. We get to see. When I was in US, also we had seen so many cases of tuberculosis, and so yes. Now the thing is, just because you have come to the fertility doctor, you're not getting pregnant, and something doesn't look good, without testing, it is not right to start any form of treatment, and especially things like AKT treatment, like anti-tuberculosis treatment. As I told, if somebody comes and presents to you and says that, oh, look, I've been trying to get pregnant, I'm getting ectopic pregnancies, and on scan you see a very thin endometrial lining or some endometrial lining which does not look so great, suggestive of endometritis, it's always nice to take a biopsy of the endometrial tissue and subject that for a TB PCR. Qualitative assay and quantitative assay, and then and see how it is, or immunocytochemistry, and see if there is any TB bacilli which is growing. If it shows positive, because all the tests, many a times when we have done PCR, immunocytochemistry, not all the tests have come positive. One is positive, one is negative. So we need to take everything into a kind of a approach and one box, and then decide the best outcome. And when we do a treatment with an AKT for an approximate duration of 9 months, and then do this treatment, yes, many of them do get pregnant. So the question to answer is, do we start empirical treatment of AKT? Absolutely not. No, we should not do that until and unless we are justified to ourselves. Yeah.
Excellent. Thank you for that answer. By the time I take the next question, can you see if you can enable your webcam? I think it is disabled, so we are not able to see you. Just have a look. Just go on the screen. If you run your cursor on the screen, on the bottom, you will see some mic and video. If you can just click on that. By the time I'll just go through the next question. This is Dr. Lal. He's our anesthetist, and he is asking, in our place, it is said that problems of males working in Gulf countries are infertility, baldness, and ureteric stones. What is your opinion whether the infertility rates are high in males working in Middle East countries?
Yes, Dr. Lal, thank you so much for this question. Gulf, sun, sun means heat. Heat is very, very detrimental to the sperm growth, and so we have seen a lot of Emirati and a lot of population in this part of the world who has stayed for a long, long time, and we have seen a very low sperm count in this group of people. So yes, we really don't know what exactly it is, but probably the heat has to play a very important role. Yes.
Okay. So Dr. Jikmik, she's our obs-gynae doctor. Dr. Jikmik is from Guwahati, I think, or further north, I'm not sure. Dr. Jikmik is asking, does L-carnitine help with quality of ovum or sperm?
Yes, we are giving a lot of the supplements for men with low motility or count. So these supplements are in place, and giving this carnitines as well as the coenzyme Q, it really, really improves the quality of the eggs. And usually our kind of protocol is to at least give for 2 to 3 months before embarking on any kind of fertility procedures. Now, understand one thing, these are all antioxidants and supplements. How molecular level it's doing the greatness, we really don't know. I mean, there is no substantial studies. It shows that this many studies were done and this much improvement. But actually in the molecular level, what is happening, we really don't know. But yes, when we give, we really, really get to see good quality eggs, good quality sperms, and also good quality embryos, and that's what we need for a baby, So yeah, we do give, and it has got a very, very important role. I'm still not able to get the video out. I really don't know. It's buffering. I'm sorry about it. It was there all this while, but it suddenly disappeared.
Yes, that's okay. Anyway, it's good to at least have the audio so that we can run the questions. There are a couple more questions from Dr. Lal and Dr. Jikmik, but I'll take the others as well and then come back. Dr. Praveen, who is our cardiologist, he's saying, we get to see very high lipids during the period of hormonal treatment for infertility, with sometimes the triglycerides going up to 1,000 micrograms. Anything to be done for these patients? Also, any studies which implicate this therapy in the development of acute coronary syndromes during pregnancy? So there are two questions to it, two parts to it. One, asking, they see very high triglyceride levels in patients who are undergoing treatment for infertility, probably stimulatory treatment. And he's asking, is there any relation are you seeing any acute coronary syndromes in these patients?
Yeah, thank you so much for this question. And I guess these are the group of people or the group of women who probably would be branded in the category of polycystic ovarian syndrome patients. And these patients are mostly good candidates to end up having metabolic syndrome later in life. And these are the ones who has got high cholesterol and triglyceride levels. Now, the second part being, do this cholesterol and the triglyceride level increase during the IVF stimulation? I really have no known studies as of now, but it is also unsure that ovulation stimulation can increase those triglycerides. Probably they had an elevated level of raised cholesterol to start with because of the hormonal disbalance they have in them, and probably these injections might act as a catalyst. So that is one part of it. The second part of it is, do they end up having coronary syndrome? Like during the time of doing the assisted reproductive treatment of IVF and all, we haven't had such adverse outcomes. But yes, we do always counsel and educate our people that probably later in your life, you are a very good candidate to end up in diabetes and hypertension and all these high cholesterol and triglycerides. And we also get to see that these ladies, their brothers and all are all having obesity, diabetes, and high cholesterol abnormalities. So yes, these are all points that can be connected together. But when it comes to a lady who is obese and hormonally very abnormal profile, we always have a multidisciplinary approach where we refer them to our physicians and take their opinion, cardiologist opinion and all, and make sure that when we are going through the whole process of IVF, the stressful factor is taking injections, so that would not adversely affect. And once we are done with the pregnancy care, is always taken care in a multidisciplinary approach involving the diabetologist, physicians, and all. And then yes, so yes, the counseling and education is for the long-term benefit, but acutely during the IVF treatment, we haven't seen as much. Yeah.
Okay, Dr. Shalaka, she's also in the OBS-GYN. She's asking, is the incidence of OHSS higher in women undergoing IVF for unexplained infertility?
Well, first and foremost, ovarian hyperstimulation syndrome, I cannot even think about those 7, 8, 9 years from now, how I used to manage. And every time I used to have mouth ulcers and all because of the stressful situation, because all these ladies used to have OHSS. Nowadays, for the past 4, 5 years, we are having OHSS free clinic because of the introduction of the agonist triggers. We make the eggs. We don't care about the PCOS. We make beautiful eggs. We get them out, and we give them not the HCG trigger. We give them the agonist trigger. We get the matured eggs, and then we do a deferred embryo transfer. And with that, the woman absolutely does not hyperstimulate at all. With the next very day, she finds 80% of her problems are all over. So unexplained infertility is a different category in the sense that it is somebody who's not able to achieve a conception. So I can either do an IUI, you can do an IVF. When you do an IUI or an IVF, you have to give injectables. When you give injectables, the ovaries which are sensitive like PCOD, they boom, they blast off, right? So when it comes to an IUI, better to cancel those cycles. Don't even go forward. If you see more than 2, please abandon those cycles, because what is happening is the moment you put the sperms inside, it's a disaster. Because if the multiple sperms goes and fertilizes multiple eggs and it results in twin pregnancy, and this lady is a PCOD, then this pregnancy, HCG secreted from the pregnancy, is going to trigger the whole cascade, and it is bad thing. We had to resort once upon a time to even do to stop the pregnancy, to salvage the life of the lady. So this is what it is. IVF, as I said, it is very safe. You make it, don't care about it, give the agonist trigger, get the eggs out, let the lady go back home, the embryo goes to the freezer, and the next cycle you put the embryo. So with that, what happens? OHS is 0. We get what we want. We put one embryo, the chances of multiple pregnancy is less, and at least 50 to 60% chances of implantation. So yes, so now OHS is I think going to be in the back chapters of our obstetrics and gynecology or infertility books, not in the front pages anymore now.
Right, okay. All right, so Dr. Manjeet, anesthetist, he is asking, thanks, very nice talk. In anesthetics, what he means is the anesthetic drugs, do they cause problems in female doctors? Have you seen female doctors who are in the OR, either surgeons or anesthetists, do they have more incidence of infertility because of exposure to anesthetic drugs? I think that's what he means to say.
Okay, let me rephrase your question. You are saying that I have an anesthetist lady doctor, and she every time gives the anesthesia for different cases. So she is exposed to these inhaled anesthetics, and does that cause infertility? Am I right?
I think that's what he means.
Okay.
Yes.
Okay. Frankly speaking, no, I would say, because exposure is the same as you and me or anybody else. I would not say that anesthetic drugs increases the chances of infertility or things like that. We have had a lot of doctors, anesthetists who had beautiful eggs and embryos, and also we had a lot of doctors who did not have. So is it because of anesthetists, or is it because of some other quality problems? We don't know. As I said, there are a lot of factors. You have the sperm factors, you have the tube factors, you have the sperm egg factors, the endometrium factors, the pelvic factors, the hormonal factors, the stress factors, the environmental factors. I think we cannot pinpoint anesthetic medications as the number one cause. Maybe later down in the line it could be, but not the major one. Not the major one.
Right. Okay. You also said there are a lot of factors, obviously, sperm factors, egg factors, and the fertilized egg factor. You made a mention about there's no way to assess the egg quality in terms of testing. So how is it done? Is it always visual? I mean, you visually examine the egg and decide what is this quality? The fertilized egg, I'm saying.
So when we do an IVF is very, very visible. You know, it's a visible treatment where we see what we do. right? So as I said, when we start doing the scans, we see the ovarian follicular development. A very nice development is an indirect indicator that things might be good inside. This is the ovary needed a little bit of push, and that's when we give a push, we take those eggs out. Once we take the eggs out, we see a cohort of eggs. Now let's put 10 eggs. We have got 10 eggs. All right. Now let me put it this way. When we go to a supermarket, and we buy a basket of mangoes, I'm sorry to give this example, but just for an explanation between us, not all the mangoes are ripe. Not all the mangoes are green color. Some are yellow, some are green, some has got black spots, some has got this, some are that. So not every mango would be of the same quality. Likewise, when we get 10 eggs, not all the 10 eggs would be of the same quality. Out of 10, in my experience, out of 10, maybe 6, 7, or 8 would be matured M2, metaphase 2, out of which, when we fertilize with the sperms, 6 will get fertilized. Out of 6, probably we are left with 3 or 4 embryos. Now see, we got 10 eggs and we got 3 embryos. What happened to the remaining 7? There could have been a problem in the egg, there could have been a problem in the sperm, or there could have been a problem in the de novo new individual, which is the embryo per se, the de novo mutation which could have happened, which we don't know, which we don't get to see. But all the cytoplasmic droplets and inclusion bodies, which I showed in the picture, the perivital in space, granularity, these are the telltale indicators to say that, listen, we have seen your eggs, it does not look so great. Probably we might not have a good embryo to implant or fit. So this helps us in counseling our patients. And the next question is then, doc, what do we do? My eggs are not good. What do we do? So what do we do means, let's continue. If it does not happen, then we might have to embark on another cycle of an IVF, probably change our injections. Sometimes changing those injections also helps. Why? Because, there are a lot of isoforms on these injections, acidic and basic and all those things. It really helps. I'm not going to get into the details of it. It really helps. And we have had a successful outcome. But in spite of all those things, if the quantity and the quality is absolutely bad, and if it's an advanced stage, probably we might have to talk about third-party reproduction. Yeah.
So you assess the quality of the eggs based on inspecting them under the microscope.
Morphological features, yes, under the microscope. Yeah. As the pictures which I had shown you before. Yeah.
So it's very observer dependent, meaning that if you are really good at it, you can get good eggs. Yeah.
If you're again, it's I would not say it's eggs are eggs. Ovaries will produce that eggs what is there. We cannot change the ovary. If the ovary is absolutely a quality bad ovary, then a good bad quality egg will come out of it. So if a bad quality egg comes out of it, we will see under the microscope it's a black granular brownish color egg. And subsequent every trial, it is the same. It means there is some problem in the ovary. Now, what is the problem? It is another Pandora's box. We really don't know, But the thing is that now we want a pregnancy. If we keep on evaluating, like, where is my egg and why is the quality 30 will become 40 years. And then, so we have to establish something called time to pregnancy. So if these eggs are not with you, then we have to resort to something else, so this is how we evaluate. But if the eggs comes good, then yes, you do trial with your own. This is how it is.
Right. Okay. Great. So a couple more questions here. Dr. Lal, the anesthetist, he was asking, just like we have ovarian reserve, is there anything like a sperm reserve for males?
Yes, Dr. Lal. Yeah, the right question. It was taken for granted. Men were taken for granted. Millions of sperms, so many, But now they have also come with this age factor in man. They also say that, listen, men, and after 34, 35 years of age, your sperm also goes for a 6, So they say that if men are not married and they have not got a pregnancy, and and if you want to delay, then get your 30, 32-year-old sperms and freeze it and keep it. Okay, because it is not about the number, because if a man has a good million sperms, my number should be okay, but probably the quality. So basically, again, back to the same concept. The younger you are, something is there in the body which makes it so good. But the more advanced you go, it gets affected by so many question mark factors, which we also don't know. So yes, but it is still not sipped into the society that men who are 35, 38, they also need to do. They will say, I have got good sperms, and why you want me to do the freezing and keep it, in a store, in a reserve and all. Ovary, it's not that you keep it, but not. So this is how the challenges we have. So we just leave it at that. We don't challenge it. But if somebody is alert and educated and they understand all these things, then why not? We have the technicalities and the science with us. So it's always good.
This is often done for people, patients who undergo chemotherapy, I think. Yeah.
Oh, yes.
This
Yes.
preservation of sperms
Preservation, yes. Chemotherapy.
before undergoing.
Yes, this is the only indication during this COVID-19 now, in the corona, that we are only eligible to do the treatment for this group of women who are undergoing chemotherapy, or men who are undergoing any kind of cancer therapy, and they want to get these eggs and sperms out of the body. So yes, it is indicated, and we do salvage, and that is the science and the guidelines which we want to propagate into the society, that if you have any diagnosed men or women in the reproductive age group who is going to start any kind of cancer treatment, and if they're still pending to have a fertility, tell them, please go and get these eggs and sperms out of your body and please store it. Because what happens is, when the diagnosis of the oncology thing comes, everybody gets so overwhelmed that, oh, okay, I have to sit and get it out of the way. And while they start doing it, all this cell, the life, the division DNA gets squashed because of the chemotherapy, and then there is nothing left for a baby. So it's always better 1 or 2 months of stimulation, get these eggs and sperms out, freeze it, keep it safe, get this cancer out of the way, come back after 2, 3, 4 years and get a baby of your own. So this is the kind of talk which we need to spread in the community. Yeah.
Right, excellent. So that's a lot of questions. One question more from Dr. Chickmick, Obscani. She's asking, is there any limits to the number of cycles of IVF that should be done in one patient?
I would start in a reverse way, right? Currently, I have somebody in my center, an American lady who's done for the 10th time, 6 cycles outside somewhere else in US, in UK, and the 7th here in Dubai, and then the 8th, 9th, 10th with us. So, and she has not yet got pregnant, and she has got eggs, she has got sperms, and this is what is the last sentence of my slide: unexplained IVF failure. She is making embryos. We really don't know. So to answer your question, we don't usually encourage to keep on doing IVF. There should be a time when you have to escalate to the next level. And again, the patient are the best people who decide for themselves, and then they themselves will tell that enough. I think we'll resort to a fate, and we will not do any more IVF, or we will see other avenues to do it. So no, nothing like that. Starting from 2, as much as 8 to 10 cycles can be done. Yes.
So what is the risk actually if they keep doing? Is there a risk of
studies have not shown, there is no scientific studies to show that IVF per se increases the risk of breast cancer, ovarian cancer, or any form of cancer, or it has a negative impact on the baby. Absolutely not. IVF is one of the most safest way to achieve a pregnancy, and once you're pregnant, the pregnancy is as same as anybody out there in the random population getting pregnant. So IVF is absolutely safe, and that is why it's done worldwide now. The only negative thing about IVF is the cost factor, which we all know that, and side effects, no. Now the thing is, the many studies which shows that IVF and the chances of ladies having cancer. Now the thing is, ask yourself, was that mutation there from before? That BRCA gene or whatever, was there from before, which did not manifest, and after doing IVF after 2-3 years, she ended up. So did IVF increase the chance, or that gene was already there? So these are the things which we have to understand. If somebody has the potential to have cancer later in life, then so be it. But IVF per se is increasing the chance? No, it is not proven otherwise. No studies have come to this fact as of now. No.
So if they're having multiple IVF failures, the next step would be to look into some kind of donor program. Is that what it would be?
Well, see, this is the stepwise treatment plan for in our infertility, kitty box. You start with IUIs, and then you do IVFs, and so on and so forth. Now, different countries of the world have got different recommendations and different guidelines as per the specific laws and nature of the land. In India and US, we have third-party reproduction. Third-party reproduction means you do donor eggs and donor embryos, and you do surrogacy, means hiring a womb. In a country like United Arab Emirates or the Middle Eastern countries, as per the Islamic Shariat law, you are not supposed to do any of this third-party reproduction. IVF is supposed to be between husband and wife. So we don't we don't do any third-party reproduction here. But if you ask science, let's talk science now, then yes, if somebody has had multiple cycles and they're not able to achieve conception with their own gametes, then yes, third-party reproduction comes into play in the form of donor eggs. If there is eggs less, if donor sperms, if there is no sperms, or both the sperms and eggs are there and it's unexplained that you're not getting, then you take a donor embryo, like take an embryo and put it in your uterus. And if the uterus is not working good, means it is beyond implantation, then you hire a womb, which is called surrogacy. Yes.
Right. Okay. Excellent. I think that more or less wraps it up. I don't see any more questions. Thank you, Dr. Partha. That was very informative. Many people have appreciated your talk. Good to have you here. Any last words you have?
Oh, well, first and foremost, thank you, Biswajit, for inviting me and, getting this talk. I'm so sorry about this connectivity. I really can't see myself in the computer. I really don't know where I disappear. But I think you can hear me. All of you can hear me. And thank you so much for the patient hearing. And I hope I was able to at least do justice to this topic and, spread some information about what happens in infertility and what happens during the coronavirus thing and all. If at all you would like to discuss, then yeah, I have my numbers and emails and things on the slides. Be in touch and stay safe, everybody, and would love to see you again together. Yeah, and it is amazing, Biswajit, you're doing an amazing job with these webinars, and it is not one specialty, it is multiple specialties. Doctors from different specialties are together and brain teasing each other, which is nice, which is very nice. Amazing. Congratulations.
Thank you, Dr. Partha. Thank you for joining us today. Excellent hearing to you, and I think with that we'll wrap up today's webinar. Just for the other attendees, our next webinar will be on the coming Saturday. We are having a speaker from Ohio, US, so there is a little bit of time gap. So mostly we'll be holding the webinar in the evening, that is 8:30ish. Let me know if you want a time change. Okay, thank you all. Thank you all. Bye-bye. Then we have you. Good.
Yeah.
Thanks a lot. Okay.
Thank you. Take care. Bye.